I invite our next speaker, Dr. Sripriya Krishnamurthy, consultant, SN Chennai. She'll be talking on the clinical program schedule and why.
Good morning, everyone. Should I turn it on? You'll be turning the timer on. I think the previous speakers have all made quite a few of my points easy. So I'm going to cover on the clinical program schedule and why we have to have it like that during the fellowship. So I'll touch upon why we need fellowships, what they need to learn during the fellowship, and how to go about it. So any person goes through a part of examining the patient by asking history, evaluating the patient, using his theoretical knowledge to interpret it, come to a differential diagnosis, do the pertinent investigations, come to a conclusion, and then based on that, treat. So anywhere in this chain, if there is a weak link, then the treatment of the patient gets affected. So at present, our postgraduate system in many places are either from smaller centers, or they have inadequate exposure to subspecialty, or they lack theoretical knowledge or inadequate surgical exposure. There is no uniformity in the quality of the students emerging from different centers. Many centers do not have any mentoring going on, and overall the clinical acumen of the students has come down. Apart from it, in glaucoma, it's a progressive disease. So it's like a longitudinal study, whereas during our post-graduation, we come across patients and we follow them up for a short period of time. So it doesn't prepare us for a disease which is going to be of a lifelong duration. MIGS is considered the in thing, and unless we do a fellowship, we are not going to know more about it. Pediatric glaucomas and syndromic diseases are also much more, and unless we are in a tertiary center, we will not have enough exposure. Post-operative management of glaucoma surgeries is almost the secret of success, and unless we follow up the patient, we will not get to know. And this is one thing that is missing in our postgraduate program, because after the first day, it is the consultant that is following up the patient. The same applies to cataract surgery and its complications too. There are many papers suggesting how, in spite of having a planned residency program, there are lacunae in that, which is reflecting in the quality of the students coming out, and also there is very little or no incentive to implement the websites where so much of knowledge sharing is available for the candidates to study and learn by themselves. Dr. Grover has given a beautiful detailed report of all that a residency program should include, step by step, based it on the ICO system and modified it to the Indian scenario. But when Dr. Gogete and all in their study evaluated it, they found there is a lack of standardization. There is a wide range of competence of the doctors emerging after their post-graduation. When compared to the last, the 20th and the 21st century, there is what we found is that the surgical load has not changed except as far as cataract surgery is concerned, whereas all other subspecialty surgeries are still almost where they were. The only thing that has changed is the diagnostics, where there is much more increase in the use of applanation tonometry, gonioscopy, automated perimetry, etc. So we do need a fellowship. But we also have to remember, when a fellow comes in, all the fellows are not starting at the same place. Each one is at a different level in the race during the fellowship. So our entire training program has to be titrated to each one of them. So our OPD observation is one thing that they need to go through, and during that, it is not only watching us evaluate the patient, seeing the findings along with us, but they also they watch how investigations are done, what is the treatment that we advise, and also how the patient responds to the investigation and the treatment. Going through the case sheets and discussing the file with the surgeon is also essential for the person to learn. There is another secret that they are also watching. They learn the art of talking to the patients. Apart from it, we as consultants also have to remember there are a two pair of eyes watching us and learning our morals, values, ethics, our punctuality, honesty, and integrity. This, if we incorporate in our training, is going to be imbibed in them, and that, I guess, is called professionalism. So this is something that they take back with us, and we have to inculcate in them. Diagnostics is the next segment of the clinical evaluation program. So both clinical applanation tonometry, gonioscopy, etc., as well as the investigational diagnostics also have to be a part of their curriculum. Unless they can do the necessary investigations and interpret them correctly, the treatment is not going to go the way it should. After they have enough exposure, then they need to be put through an independent phase of work, where they do it under guidance. That way, it helps them clarify doubts and also builds them self-confidence and skill in a safe manner. Once they have done independent work under guidance, then they can go back to the peripheral centers or the community services and implement it in their clinical practice. That way, they also gain confidence as well as the patients also gain the skill of a trained doctor. Scrutiny of the files is very, very essential. By scrutinizing, one, the trainer comes to know whether he is maintaining the standard of eye care that he is supposed to, and also comes to know where a particular individual is lacking in his curricular level of development. Next is the most favored portion for any student, which is the surgical observation. So here, I believe that 90% of surgery is in observing surgeries. You learn different techniques, learn behavioral patterns of surgeons, learn different skill sets, and also going through the file for the patient who's undergoing surgery will teach you how and when to operate upon a patient. Wet lab definitely helps learn their skill set faster. It also gives the weaker surgeon the chance to catch up with the others in contemporaries in his batch, and also in short-term programs, it does reduce the time period that they need to learn. Virtual reality is great in that it is objective because it gives the objective score for the candidate without any interference from the trainer. The surgical hands-on is the last thing in their training segment, and this has to be under supervision because in a short period of time, the candidate has to learn his skill set. At the same time, the patient has to be safe. And whoever supervises them has to have the thing that they have to transfer the skill to this trainee. In the West, there is so much of importance given, almost equal importance given both to the primary surgeon as well as to the observation that is done. Logbooks, case discussions, and listening to lectures and participating in that also are a part of their training system. A little bit of medical statistics, there are so many websites just like this I just mentioned, also helps the candidates interpret the glaucoma journals, especially because it's full of statistics, and also helping with the publication in the institute and a little bit of paperwork builds self-confidence in the candidate, gets them to be known in the medical field when they start doing paperwork, and also breaks the monotony of too much of clinical overload. In our country, the Medical Council has detailed affiliation guidelines for awarding fellowships to a center, but there is no fixed protocol yet for certifying the candidates that are emerging after fellowships in different institutes. In the West, like Dr. Meenakshi and Dr. Grover mentioned, there are so many structured programs that are done where the faculty are also evaluated whether they are capable of conducting a fellowship under them, and also there is communication between the center and the governing body to ensure that they are delivering the goods. And the trainee also has to give a feedback about the center back to the governing body so that the quality of the candidate emerging after a fellowship is uniform across the board. So the ICU, as you all know, have so many systems both for surgery as well as for OPD, and the SIM Oscar is now available for the trabeculectomies. But what I want to highlight about the OSEX is that they give so much of importance to the history taking, to the empathy, the explanation of the clinical situation to the patient, and communication with the patient, which is, I think, a skill set that every candidate has to learn from us and incorporate in their program. Like Dr. Dave mentioned, mentoring is very important, and all this fellowship program will become successful only if there is a proper mentoring. The mentor's aim is to guide the candidate and motivate him through the program, monitor his progress because some may be lagging behind for different reasons, as Dr. Meenakshi mentioned, and also troubleshoot both his personal as well as his training-related issues. A mentor, I personally feel, should be neither too senior nor too junior, but also should be very approachable and, most important, interested in teaching and training and sharing his time and space with the trainer. Evaluating the program. This is one thing that we all have to think about because evaluation also leads to criticism, and unless we can criticize ourselves, there will not be course correction. The APO FCC has a beautiful way where they have an exit survey where excellent questions are asked both about the institute as well as what training they underwent. They even check whether the faculty who are fellowship trainers are having enough adequate clinical load practicing, which they are practicing. Clinical material they have, adequate teaching they have, surgical logs, everything is given back to the center. So if we incorporate all this into our fellowships, then we can make our fellowships very interesting. And what does the institute gain by making a fantastic fellowship? It gives a good ophthalmic care to the nation if you want to make it look good, but also it makes us get better fellows into our institute. And of course, if their fellowship is good, they are the best ambassadors for the institute. And for the fellow, it gives them catch-up time by doing a fellowship. He learns from the clinical load, and remember that specialty practice helps him survive in the world, and it also acts as a launch pad for their private practice. It gives them the confidence to face the world. Thank you so much.
Thank you, ma'am, for the wonderful talk. How often do you evaluate your fellows or PGs, ma'am? And if they are a slow learner, what do you do differently to enhance their performance?
Actually, we have to divide them into postgraduates, short-term fellows and long-term fellows. If it's a postgraduate, then it depends, it varies in which segment they are lacking. So if it is going to be, whether it's the thesis-related work in which they are lagging behind, or whether it is a clinical work or a surgical work. If it is a surgical work, then we put them through wet lab training. And sometimes, many times we have found that if we go and supervise, generally I do a lot of supervision for surgeries. So I take on the trainee and see what is the reason why they are lagging behind. Sometimes it's a mental block. 3, 4, 5 surgeries, they have had back-to-back complications, then they just freeze up. And then what happens is they get worse because they try to overdo every step and they run into trouble. So at that times, there have been occasions where I have told them to stop operating. It's not that they have to be pushed every time into a wet lab to get them out of it. If you think that their hand is okay and their attitude is okay and it's just that they have a mental block and they are paranoid about their surgical skill, stop them from operating. Just allow them to observe. Then one day, take them back after a month under your supervision and you'll find it's a transformed surgeon. If you feel that they have tissue handling is not okay, then definitely they have to go back to the wet lab. Until their wet lab tissue handling improves, they should not be coming back to the human eye. Making them observe surgeries, and when they observe, what you should tell them to do is watch the surgeries from outside the microscope. Many times when we watch surgeons operating, the instruments walk in beautifully into the eye. So everything goes very well. But what actually is missing is that the candidate doesn't know how to instrument. So make them watch outside the microscope, how to hold the instruments, how to introduce the instruments into the eye. So when you're doing it, if you explain that and make them watch that, you find that next time they can practice that in the wet lab, and then they find that what suturing they found difficult or whatever step they found difficult has suddenly become easy for them. So it varies on what stage they are in.
True, ma'am, but in my observation and experience, if we tell them to stop a surgery, they take it in a negative way. And how do you put it and make them understand?
Very,
Whatever
very true.
explanation
Very,
we
very
give,
true. In spite of my attempts, there have been 1 or 2 who still have they put me black marked. But most of the time,
Especially
what I do is
the short-term fellows, when they come for only about 15, 20 days or 1 month, we have short-term fellowship as well. And if you ask them to stop, they come all the way from different parts of the country, and they are all practicing ophthalmology. That's a big problem. So it's very difficult. It's a double-edged weapon, actually.
Very true, sir. Very true.
Yeah.
But generally, we don't do it for the short-term fellows. Short-term fellows, we push them into the wet lab. We give them intense wet lab training. And I tell them, whatever is your number, 20, 25 numbers, whatever numbers, don't worry. Even if you're behind the others, we will soon do the catch-up. So I give them, they do a wet lab for a week or something. Then when they come back, instead of 1 surgery, they are doing 2. So at the end, when they go out, they are at par with their friends. Because if we end up taking over the surgeries every time, then they are still not going to be happy. So we might as well give this a shot. But I am talking for the long-term people. I always first tell them, okay, you do this correction, you come back. You do this correction, come back. After 3, 4 attempts, if it is not working, it is also depending on whether it's their skill or it is because of multiple complications that they're having back to back. Only for those people who are having multiple complications, and when the instrument, you realize they're holding the instrument so tight, they're sitting like that, rigid like rigor mortis, then you know that they have to have a break from surgeries. If they are relaxed, and there have been people who have stereopsis issues. We have people who have instrumented above the cornea thinking they are doing capsulotomy. Those people, when we just take one look at them, we know that it is a stereopsis issue. And I have sent so many people to Dr. Meenakshi to evaluate, and then we put them through the entire orthoptics course. And those people, their eye has to be aligned before they come into the theatre. So what we do is 8 o'clock we send them and their eyes are rested to the orthoptics clinic. They finish their orthoptics, come back, and 9 o'clock is their surgery. So when we do like that, there is a sudden transformation in their surgical skill, and that is the greatest bonus that a trainee can have. When he can do something well, he gets so excited. And then it's up course.
I instruct all my PGs to first undergo refraction and orthoptics complete evaluation and then start.
Let me tell you one thing. They do all that, but There are people who manage to get an absolute 100 on all that, and then still they cannot see under the microscope. And stress also makes them accommodate so much. I have, even just last week, I had put myself in +8, which was the maximum that the side piece could reach, for me to see at least something that the student was seeing.
Okay.
That is the amount of accommodative spasm they have. And one person I dread supervising are the young myopes. They have fantastic accommodation power. So we have to be ready to.
I think one of
battle
the
them.
major issues in the training program is that the ophthalmologists or the fellows or the postgraduates, they have difficulty in using the microscope.
Very true.
I think we have training wherein for 1 week they sit under the microscope and do the XY, do the up and down,
Very
fine
true.
focus, and foot switch coordination. And the microscope, because if they don't see well, obviously they're not going to operate well.
Very
That's the main thing. So usage of the microscope, operation microscope is, I think, is a key factor.
Absolutely.
Before I think.
Especially four-limb coordination is so difficult. You have a very
Absolutely.
valid
Yes,
point.
Yeah.
I think wet lab is very useful there because they get
Absolutely.
to, we get to practice everything
Yes, sir,
before.
yes, sir, correct. Yeah.
Thank you so much.
Thank you.